Hope anybody can see and hear me.
Yes, we can hear you now, Martin. Yes, go ahead.
Sorry. Yeah.
Can you hear us?
Yes. Okay. First of all, this is a case with a nightmare scenario, and I want to speak about it. It was a 44-year-old man with depression and a condition after a stroke with complete hemiparesis on the left side. This is the medical history. And what he became is arthroscopy in the right knee, and typical for a normal patient, and what's doing an arthroscopy way. And after that, there was a swelling right leg after the surgery, and the neurological measurement of nerve conduction velocity was normal, but suspected from the internal thing was a thrombosis after the ultrasound on the day 3 after this surgical intervention. On day 6, the orthopedic and the reconsulting was sent to the vascular surgeon on the clarifying the thrombosis at that way. And at that point, he comes to our clinic, and we see on the 7th day this picture and this leg, and you see this is not normal for us for thrombosis. And what we see in the laboratory is a high CRP. It's a high identification for this infection, and a high grade of AST, GPG, and laboratory inflammations. And the HB in the hemoglobin was very low for this patient and a young term of that. In the CT angiography, there was a identification on the popliteal area where the surgical intervention was, and you see there's a rupture in the area and a swelling area and an hematomia. And what we identify in the angiography is a normal arteria in the SFA area, but then there was a rupture, and the outflow was very, very low. And it was very terrifying to see this young man at that area, how we can treat it. And in our opinion was very low. So we supposed to do it endovascular and not operational in that area. So we measured that area. It was a rupture of maybe 5 millimeters. We do a pre-dilatation with a POBA balloon. And after that, we covered this rupture with a normal wire vein, this very, very flexible area. And it looks primarily a little bit better, but the outflow was very poor that way. And what we identify is the outflow is very low, but in that case, it's very important to see how the normal tissue is that way. So there is a very specific compartment syndrome in that way. And in this case, the normal pressure is under 10 millimeter Hg. And in our case, it was over 180. So we have a compartment syndrome in that area, that young person, after 6 days or 7 days in that area. So what we do is a fasciotomy in that way in the lower leg for this young patient. And here you see it. The muscle is popping out. It was at that time very vital. So we have some opportunity to save this leg. And after that, we do another angiography. And you see it's very easy that all the vessels come through the legs again. So it was very helpful for the patient, but at day 20, the avital muscles come through and through, and the tissue damage was that worse that we have to amputate the whole leg. And for that young patient is a very disaster, in my opinion. But as a vascular surgeon and as an endovascular specialist, in my opinion, it was the best treatment to go endovascular first in that way and to hope to get the better tissue. But it was maybe too late for that one. So in my opinion, it's the best way to go endovascular first, but it's very disaster case. And I want to present it to you that everybody has to save the time, and time is tissue, and we can't forget that one. So thank you very much for your attention.
great case, Martin. It's a sad outcome. I just wonder, there was a 7 days delay until you guys got contacted. So my first question is, do we know what was the delay for? The second thing, I'm just curious, why, if you know that probably this gentleman has an injury, arterial injury with the hematoma, and you have a high inflammatory markers with the CRP of 37, and there might be an indication there's some infection, why didn't you think of repairing it surgically, evacuating the hematoma, sending samples, and do the fasciotomy at the same time as well?
At first, I mean, we have a great orthopedic surgeon clinic in our hospital at that time, and we see some damage with the arterial in that area, especially after surgical intervention in the knee. So it's not that, it's very common. So we see in the year maybe 10 of these damages, and we do it open surgical with bypass, and we do it in sometimes endovascular. In that special case, the person was sent at home, and then there was a delay between the consulting for orthopedic surgeon, and there was the opinion that the patient has an thrombosis in the knee. So that delay is maybe the worst case that a patient can have, especially that is a hemiparetic on the left side in a young patient. So they really need this leg. This is one explanation, and surgical opinion for this hematoma get out in a surgical way, I don't think is the best way for that one, because in the CT we don't see that it's that much high-graded hematoma. So maybe this is the answer for your question.
Right. Okay. Any other questions from? Yes, please.
Just a comment to remind all of us how you can get a nerve conduction study before you do a pulse exam with one your hand and find that it's pulseless leg compared to the other leg in a young patient.
Yeah, this is a demonstration that the orthopedic surgeon go for first in a nerval or a neurological consultant instead of a vascular surgeon. So this is a damage for the patient. Yeah.
One more question, since you have great experience with the popliteal injuries after orthopedic surgery, and you treat many of those. I was surprised about your sizing of the artery. The covered stents like Vibon, they do very well with bending, but at the same time, their patency goes down significantly when they're not sized one-to-one, when they're oversized.
Yeah, we do it a little bit more oversized for 1 or 2 millimeters in that area. But you're right, yeah.
Well, Michael, one other question. In the video, you showed opening up one compartment. Did you open up all 4 of them?
Yes, of course. There was only the video in one segment, but we do all of the compartments to get it open. Yeah, you have to. Yeah.
Last question.
Thank you. In young patients, obviously, this guy is quite different because he's hemiplegic. But in young patients, if they come with an acute injury following orthopedic or trauma, and we place this, and I agree, endo is very good in the acute phase because you're dealing with a big hematoma. But I do place a stent, but I consciously place it as a bridging procedure. And I do it until the hematoma settles, and then I bring the patient back and do the definitive bypass. Because, we know that all the stents, they call stent patency in the FEMPOP segment, but it's always, the adductor canal segment. But we know behind the knee stents don't do well long term. So in young patients, I do place in the acute phase, get the hematoma settled, bring them back, and then do the definitive bypass. So what are your thoughts?
Yeah, it's a good idea. In my opinion, it's nearly the same, but we have to prepare the patient first in the first step that we become normal flow in the upper part of the extremity. So the main problem was the delay, and the second problem is, in my opinion, the compartment syndrome. So we have treated it in that way. And second one, maybe you got you can do the bypass after the delay in some days, yes. But why do you do it first step? So you are absolutely right. Maybe the stent can close or something problems can become. But in the first step, you have to treat the rupture and the compartment syndrome, in my opinion.
Martin, thank you very much for sharing this complex case. I think it's time to move to the next one.
You're absolutely welcome. Thank you.
I think the common factor between the open vascular surgery and the endovascular surgery is a high incidence of nightmares. But the vascular surgeon is a brave surgeon and should not be afraid of any nightmare. Even I think he cannot sleep to have nightmares. The next talk, Mr. Wael Tawfiq and his first case of aortic nightmare.
Thank you very much, and thank you, Professor Mahmoud Salah and Dr. Ahmed Saar, for the kind invitation. Can I have my slides, please?